Thank you, Chairman. Dr. Arkoosh, thanks to the bill passed by the Republicans in Congress, Pennsylvania received hundreds of millions of dollars for rural health this year through the Rural Health Transformation Plan. You said that the state will operate a rapid response access stability program in the first 2 years to preserve essential hospital and EMS capacity. Which facilities have been identified as eligible? How much funding will be available, and when will the funds be released to prevent near-term closures?
Yeah. So I would love to be able to answer those questions. I'm hoping I'll be able to answer those questions in about 2 to 3 weeks. We are finishing up our contracting with CMS, and we're very close to being done. And then we are working on our own internal processes with the comptroller's office to set up the mechanism for those access stabilization funds to go out. Our plan is to have a very public webinar as soon as I can give firm answers to those questions in the next, hopefully within the month at the latest. We'll make sure all of your offices know about that. Obviously, it will be recorded so that anybody who can't get to it can access it. And we'll go through all of the mechanisms that will be in place for people to apply for that funds, those funds.
Thank you. And do you have an estimate on the or a timeline on when the hospitals might be able to apply?
It'll be as soon as we're up. Like, as soon as we have that webinar, we'll be able to, we believe we should then be able to go live. Like, we want to just have it ready to go and then hit go. That's our goal.
And I know the chairwoman and I both would appreciate notification as soon as you have that information.
Absolutely.
Because funds are distributed through the PrEP regions that include both rural and urban regions, what safeguards are in place to ensure that that funding, which is specifically allocated by the federal government for rural, are not going to urban areas?
So, couple things. So there has been a slight, one of the things that we did get back from CMS is a slight change in how we will establish the relationship with the PrEP regions. So we are still going to use the region, like that we had originally outlined in the grant.
Yes.
And by the way, everybody has some of this. We will be working with their teams to help convene these rural care collaboratives that will meet regionally to prioritize the needs for that region. There will not be funding going through the PrEPs. CMS has told us that's not allowed. So they'll be working with the regional care collaboratives and a staff person that we're going to hopefully co-locate with all the PrEPs. So we'll be very much working together, but the money is going to have to come through DHS. So
Again,
there's that piece.
I just want to make a point here. I'm not against the the urban hospitals. I know we've been the canary in the coal mines, and we've been getting the shutdowns a lot faster and earlier.
Right.
That's why.
Yeah, well, I do want to answer that part of your question. So the notice of award, and well, actually the original funding opportunity prescribed where this money could go, which is in these HRSA designated rural regions. And then we could, if there was a HRSA designated rural region, we could also include that whole county. So that is basically what we did with some exceptions. For a hospital that is in an urban area, the way that they could potentially participate in this would be if a hospital in a rural community initiated a request to say, hey, you do really good remote patient monitoring. We would like to contract with you to do remote patient monitoring in our emergency department or our ICU. And they could contract with an urban hospital who provides that service, but it would have to come from the rural hospital requesting it.
And only only those services would be.
Correct. So an urban hospital can only participate at the request of a rural entity for a service that the grant covers being conducted in a rural community.
Now, nursing homes. Right now in Bradford and Coudersport, I'm down to just one in each. They're the last standing ones in the communities, and it's, again, rural impacts have just been horrendous. What percentage of the dollars that we have, that we appropriate for long-term care actually make it to those facilities, and how much is actually held by Medicare, Medicaid brokers? It's important to me because it just...
Yeah. I'm not sure what you mean by the brokers. Like the funding goes directly to nursing facilities for any Medicaid patient that they have that meets eligibility for nursing home care. The funding to the nursing home gets paid directly for that patient. For the folks that are in our Community Health Choices program, who are
Right.
all nursing facility eligible, 79% of them are being managed in the community with home and community-based services. But that's a choice that the patient has made. There's not, we do have the independent enrollment brokers, maybe that's what you're referring
Yes.
to. They do not get funding for, they just get paid a flat, basically it's a flat rate. They don't get bonuses for sending anybody any which way. They are just independent arbiters of sharing information with the folks who are eligible for these services.
How's that fee
Does
set
that
up?
answer your question?
Well, just how is that fee set up? Is that, but there's none of that taken out of the money for the nursing home?
Nope. No.
Right, thank you.